Only by enabling data sharing and a unified health summary for each patient can we support continuity of care when patients move between different healthcare settings and receive care from multiple healthcare providers. The members have raised a number of thoughtful views and constructive comments, which I'll address them in 4 broad themes. But before I do that, I would like to address the points made by Mr. Kenneth Tiong, a member, around the organization and his views on Synapxe, the health tech agency that implements many of the IT projects in MOH. As that topic does not pertain to the specifics of the HIB, I encourage Mr. Tiong to raise a separate PQ or raise the issue separately from today's debate. But suffice to say that Synapxe is not a commercial entity. Its fundamental role is to support MOH in delivering digital health and IT services to benefit our healthcare clusters to deliver better healthcare services to our Singaporeans. Let me now turn to the substance of the bill. There are 4 broad themes of comments that came in. First is around the safeguards for patients. Second, the obligations and support measures for healthcare providers. Third, the support measures for healthcare professionals. And fourthly, the sharing of non-NEHR health information. Let me start with the safeguards for patients. Mr. Yip Hong Wing, Mr. David Ho, Mr. Wan Rizal, Dr. Hamid Razak, and Mr. Fadli Fauzi highlighted the importance of safeguarding access to and the use of patients' NEHR information. And this has been a focus for us when we carried out the public consultation and prepared this bill. There are broadly 2 sets of concerns that we hear from individuals. The first is how a patient's NEHR information will be adequately safeguarded and assessed only as needed by healthcare professionals and providers. Of special concern is the access to health information that may be deemed more sensitive. There were also related questions about the access restriction features. So that's the first set of concerns. The second is around whether the NEHR information will be used beyond healthcare, such as for employment and insurance purposes. Let me touch on the first set of concerns. Sir, we are not starting from scratch. We have been operating the NEHR for 15 years. Importantly, the vast majority of healthcare providers are already on board. All public healthcare institutions, most private hospitals, and the bulk of the GP clinics. So this is a system that is operating for many years. And we have built in various ex-ante safeguards into the design of the NEHR. This includes role-based access, such that authorized healthcare professionals can only access the types of health information required for their specific patient role. We also have technical controls and regular ex-post audits to flag unauthorized accesses to NEHR. With the HIB, we are enhancing the legislative safeguards and stiffening penalties for unauthorized access. First-time offenses of unauthorized access of NEHR are punishable with a maximum fine of $50,000 and or up to 2 years imprisonment upon conviction. And the penalty is doubled for repeat offenders. And healthcare professionals who access NEHR in an unauthorized manner could also be referred to relevant professional boards or councils for further action. Mr. Dennis Tan spoke about offences and whether the $1 million maximum fine was sufficient. Well, sir, the jurisdictions he compared with, as well as PDPA that he referred to, don't have criminal prosecution. The breaches to HIB is serious, and we take this seriously. And for example, if you can conviction, it's not just fines, it's imprisonment as well. But more basically, we take a approach that is more supportive, working together with our healthcare providers and healthcare professionals. These are people, nurses, clinicians, administrators, who want to do well, who want to serve the patients, want to take care of the patients. And we want to take a supportive role and approach to uplift data security and cybersecurity postures, not a punitive approach. Mr. Alex Yeo asked about audits on unauthorized accesses of the NEHR, and Mr. Tiong asked if Synapxe would proactively monitor against unauthorized access. Synapxe, the NEHR system operator, conducts regular audits and ongoing monitoring to detect suspicious behavior or atypical patterns, including in response to patient alerts. For example, assessing the NEHR information of a patient who has not recently visited any healthcare provider is a flag. Synapxe will conduct investigations to determine whether an unauthorized access has occurred. Synapxe will regularly review its audit plans, including frequency, best practices, and the use of new tools like artificial intelligence to ensure that the regime is robust. In addition, instances when a patient's NEHR information is assessed over the preceding 12 months will be made known to him through the NEHR Assess History feature in the Health Hub application. This provides an additional layer of transparency. Patients can monitor which healthcare providers have accessed their NEHR information and flag any unauthorized access to the authorities for investigation. The logs will show access at the healthcare institution level to keep the function simple, usable, and practical. In a multidisciplinary team, healthcare professionals across different roles may assess the patient's NEHR information at different times of the patient's care journey. Depending on the patient's condition, it is also not uncommon for nurses, pharmacists, or allied health professionals to need access. In a healthcare system, the institution is ultimately responsible for care to its patients. I would like to take the opportunity to clarify the comment made by Mr. David Ho. Health Hub access logs will show all access to NEHR, regardless whether the access is through EMR or the portal. So just to clarify on his point earlier. So I would like to assure Mr. Ho, Mr. Fadli, and Mr. Yip that we will seek users' feedback when reviewing the interface to ensure it's simple and user-friendly. Mr. Speaker, we understand that some patients are particularly concerned about access to health information that may be deemed more sensitive. Mr. Louis Chua, Mr. Yip, Dr. Razak, and Mr. Ho, and Mr. Tiong himself have commented on the need for safeguards for such information. And such health information includes sexually transmitted infections, delusional disorders, and schizophrenia. The diagnosis and test results that confirm the condition are subject to additional safeguards. First, there are restrictions on who can access this information. Only a select group of healthcare professionals are allowed to access this information based on their role in caring for the patient diagnosed with the health condition. For example, a nurse who is working in a psychiatric ward will have access to the psychiatric condition of the patient he or she is caring for. So that's the first control. Second, before an authorized healthcare professional can access these types of health information, they will be subject to a double lock-in, which requires the authorized healthcare professional to re-verify their credentials before access. This ensures that such information is only accessed when needed and avoids accidental access. Accesses to such health information are more closely audited by Synapxe, and cases of unauthorized access to NEHR information will be investigated and penalties imposed. So we appreciate that despite all these safeguards, some patients may still have privacy concerns. To assuage the concerns of these patients, the HIB will allow patients to restrict healthcare providers from accessing their NEHR information, or we call this access restrictions in the bill. As I mentioned earlier in my opening speech, we do not encourage this, as it could lead to adverse impact on care delivery for the patient. So to address the queries raised by members, the access restrictions have been designed to balance the impact to patient care, considering the welfare and interests of the patient while taking into consideration their concerns around privacy. So patients may restrict access to the NEHR information at the healthcare institution level, but not at an individual healthcare professional level. As I mentioned earlier, care delivery is team-based and increasingly multidisciplinary. It's not operationally feasible to restrict access to specific healthcare professionals, but not others, when they all work in a team in the same healthcare institution. This is aligned with good practices we observed elsewhere, like in Australia. Health information will be contributed to NEHR even if access restrictions are in place. As pointed out by Dr. Hamid, who brings in a practitioner's perspective, an incomplete record, including if individuals opt not to contribute select healthcare information deemed to be more sensitive, will significantly reduce the utility of NEHR in supporting healthcare professionals to provide quality care and could pose safety risk. In certain situations, access to such records in a timely manner could save lives, as I mentioned earlier in my opening speech. One example would be when a doctor or pharmacist need to have the ability to assess drug interactions, and his job is hindered due to incomplete medication information. The patient could suffer unintended consequences, especially in emergency situations where the patient may not be able to respond. It also ensures that if patients change their minds in future, for instance, when they are older, and remove such access restrictions, there will be no gap in the NEHR information, and this was a valuable learning point when MOH colleagues engage other jurisdictions. The approach you are adopting aims to achieve a balance between patient choice and ensuring that patients receive better and more coordinated patient care. So in summary, healthcare providers will be granted access to NEHR to support patients' continuity of care across healthcare settings by default. Patients may, however, restrict access to all healthcare providers, or from the second half of 2026, limit access so that only select healthcare providers, such as their own Healthier SG clinics, may access their information. Once in place, restricted healthcare providers will not be able to, unless required by other written laws, access the patient's NEHR information, except for the essential subset of records that deals with allergies and vaccination records. Next, I would like to also thank members like Mr. Yip, Mr. Ho, Mr. Chua, Mr. Fadli, and Ms. Kwa Boon Teng for highlighting the importance of educating the public on the implications of placing access restrictions and supporting patients that are less digitally savvy. We are likewise mindful of this point. MOH will work with the healthcare institutions to set up physical touchpoints for those who require help with placing access restrictions and understanding the implications of doing so. Alternatively, patients may seek the help of trusted individuals like their family members and caregivers to place access restrictions on their behalf. Mr. Ip raised the concern that the act of placing an access restriction may itself become a source of stigma or adverse inference. This access restriction will be known only to the healthcare providers managing the patient, and all healthcare professionals are bound by their respective professional bodies' ethical codes and ethical guidelines to treat all patients fairly and without prejudice. Let me now move to the queries around NEHR access by insurers and employers. We understand Singaporeans' concerns about the potential discrimination or stigmatization they may face if their health information is revealed to the employer or insurer. On this, I would like to reiterate 3 points that I made earlier in my opening speech. First, insurers and employers do not and will not have access to NEHR. Second, healthcare professionals are also prohibited from accessing NEHR for employment or insurance purposes, except for prescribed statutory medical examinations, which I will talk on later, or where authorized by other written law or the order of the court. Third, the HIB imposes strict penalties for any unauthorized access to NEHR, with higher penalties for prohibited employment or insurance purposes. Mr. Wan Rizal asked whether statutory medical examinations may provide a backdoor for employers to gain access to NEHR information. The list of statutory medical examinations that is in the bill is tightly scoped to those where NEHR access is necessary to protect the public and safeguard the health of the individual. This is the key principle. We have no plans to expand this list to include employment-related screenings that are not necessary to protect the public and the individual. The current practice for employment-related screenings will remain, where doctors rely on their history-taking, clinical assessment, and their own existing medical records for the individual, if any, without access to NEHR. On Mr. Yeo's query on whether MOH will consider allowing individuals to give consent for their NEHR information to be accessed for insurance purposes for some situations, I'd like to reiterate that NEHR is primarily for patient care purposes. When insurers request for health information, the current practice is for healthcare providers and professionals to rely on their medical records, patient interactions, which include history taking as well as physical examinations, to prepare the necessary reports for the insurer. This will continue to be the case after the HIB is enacted. NEHR must not be assessed for such insurance and employment-related checks. To Mr. Tiong's query, healthcare providers and professionals should prepare separate medical reports, memos, or clinical summaries for the insurer, instead of providing their raw medical records, such as printouts from their clinical medical records. This is because raw medical records contain extensive information, including potentially irrelevant information. Where NEHR information is referred to during a medical examination, information relevant to the episode would be validated or confirmed with the patient during history taking and may be captured in the provider's own medical records together with the doctor's clinical assessment. Such information would then be treated as part of the provider's own medical records. Healthcare providers and professionals will need to carefully assess what information is in their own medical records is relevant and necessary to include in a report provided to an insurer. MOH has issued a circular to healthcare providers and a guidance note to insurers to clearly state these positions. Healthcare providers may inform MOH if there are any inappropriate requests for NEHR information for insurance purposes. Sir, let me now address questions about the contribution requirements in the bill. Dr. Haresh asked if mandatory contributions coupled with access will encourage episodic care, affecting initiatives such as Healthier SG, which encourages building a trusted relationship between patients and their family doctor. Mr. Ho asked about the requirement to contribute information in a timely and accurate manner and the treatment of overseas medical records. And Mr. Fauzi asked about the level of details of key health information to be contributed to NEHR. The bill requires healthcare providers to contribute accurate and complete health information in a timely manner. This ultimately benefits patients by enabling their healthcare providers to access all relevant health information to provide the best care. Take a Healthier SG family doctor as an example. The bill will allow the doctor to deliver better patient care, taking account of the patient's medical history across different settings, including private specialist clinics. This enables the doctor to build a trusted and hopefully lifelong relationship towards better health outcomes. And to help healthcare providers comply with the contribution requirements in the bill, we have whitelisted Health Information Management Systems, or HIMS, HIMS, that have the requisite technical features and encourage all healthcare providers to subscribe to this HIMS. On overseas medical records, the HIB only applies within Singapore. Nevertheless, patients can bring their overseas health records to their local healthcare providers, who may then incorporate relevant information into their own medical records. And once incorporated, these records will be contributed to NEHR. To Dr. Hamid's query on whether populations that receive care outside the conventional system, such as prison inmates, will benefit from the bill, I'd like to assure a member that all Singaporeans' key health information, including those under the care of the Singapore Prison Service, will be contributed to NEHR. To Mr. Fadli's query of NEHR designed to be a One Health summary, we will only require the contribution of health information prescribed in the first schedule of the bill and not the doctor's detailed clinical notes. The design of system and the data pipes take in only the prescribed data types. For example, if a patient has diabetes and is prescribed with insulin, the doctor will only contribute diabetes as the diagnosis and insulin as the medication. So only information that's needed for continuity of care. So let me now turn to Dr. Chu Pei Ling's suggestion to extend NEHR access to other users, such as allied health professionals working outside of licensed institutions. I would like to thank Dr. Chu for her suggestion to extend the access to other users. However, I'd like to reiterate that the primary purpose of the NEHR is to support and enhance the continuity of care for patients. Hence, HIB provides for NEHR access for licensed healthcare institutions, and within these healthcare institutions, NEHR access is only provided for healthcare professionals with clinical or care planning roles, and this is the core principle governing NEHR access. However, we recognize that as care models develop and evolve, we may need to grant new providers or services access to NEHR. In doing so, we will consider factors such as whether NEHR information is required for that role and whether the provider or service is able to comply with HIB's requirements. And prior to changing the scope of providers that may access NEHR, we will consult relevant stakeholders and publicly communicate the changes through the MOH website. Sir, Mr. Chua, Mr. Louis Chua, Mr. Yip, and Mr. Fadli Fauzi also asked about sharing of NEHR information for non-patient care purposes under the HIB or other written laws, such as the Criminal Procedure Code 2010. NEHR was set up to facilitate patient care, and the information within NEHR is primarily intended to be shared across healthcare providers for that purpose. And this is a consistent principle adopted by other jurisdictions that we have studied. And MOH is of the view that the identifiable health information should generally be interpreted and managed by qualified healthcare professionals. Parties from outside the healthcare sector generally do not require identifiable health information for non-healthcare related purposes. Such, therefore, when parties seek MOH's views on this, MOH would suggest that such parties consider alternative data sources or ways of achieving its policy intent instead of using NEHR information, or involve the qualified healthcare professionals to partner parties in meeting the intent. For public health purposes under the HIB, NEHR information may be needed in certain situations, for example, to quickly identify and enable healthcare providers to contact affected patients in the event of a major drug contamination incident. As another example is in the event of an outbreak of a serious infectious disease, there may not be sufficient time, nor will it be feasible to seek consent from the individuals to use their NEHR information to contain the outbreak. So de-identified NEHR information may also be needed for public policy analysis and planning purposes, such as to review healthcare utilization trends or to analyze the cost effectiveness of medicine. So I gave some examples to the queries that raised by members on the scenarios in which those clauses apply. As a general rule, MOH will ensure requests for NEHR information have sound basis before supporting it. For all supported requests, whether from private entities such as academic institutions and health-related organizations, or from public agencies under other written laws, MOH will share only the necessary data required to fulfill the intent. Let me give an example to illustrate my point. For example, we request from the police to locate missing persons. We will only provide administrative information about visits to healthcare providers without details of the patient's medical conditions. This enables the police to confirm if missing persons have been warded in an emergency and in turn alert worried family members. Requesting parties will also be required to protect the data against loss, against unauthorized access, use, modification, disclosure, or other misuse. Mr. Chua and Mr. Fadli asked specifically about the use of NEHR for research. De-identified NEHR health information may be shared through established platforms such as Trust under the NRF for research purposes. This could include training for artificial intelligence models, but where requests are received from commercial parties, possibly for commercial purposes, we are extremely cautious in assessing such requests, including whether the sharing of such data is helpful in contributing to better healthcare and better health outcomes. Primarily, NEHR is for continuity of care and for public health purposes, not for commercial purposes. Mr. Chua suggested allowing access restrictions to be applied to the sharing of NEHR information for broader public health interest purposes, such as policy planning and analysis. This is not advisable, as it could lead to incomplete analysis and will undermine the utility of NEHR in informing national policies and planning. So now let me turn to the third topic around resilience security of the system. A number of members, including Mr. Yip and Mr. Dennis Tan, asked about the resilience and security standards for NEHR, particularly in light of the SingHealth data breach in 2018. I'd like to reassure members that MOH has taken in the recommendations under the Public Sector Data Security Review Committee conducted in 2019, and NEHR is complying with the relevant resilience and security requirements for government systems recommended by this committee. NEHR is subject to security and resilience audits with vulnerability scans, penetration tests, and exercises carried out regularly to ensure that systems are secure and backup systems are operational in event of a downtime. I must add that really the lesson for SingHealth data breach is that we are open and transparent about the issue, convene the committee of inquiry, learn the lessons, apply them, and make sure we work very hard to prevent such breaches from reoccurring, and take those lessons into heart as we build up our security and data security cybersecurity and data security standards. And we have done so over the years. Additionally, there are several lines of defense before the NEHR database, with intrusion detection at various parts of the network. Timely hardware and software application upgrades are implemented, which include security patches as well as security controls to detect and block suspicious traffic from external sources. MOH and Synapxe will continue to work with the Cybersecurity Agency of Singapore, GovTech, and independent auditing firms to conduct regular cybersecurity reviews and security assessments. I would like to also thank Mr. Yip for his feedback on the need to make NEHR more user-friendly. I'll assure him that we'll continue to invest in improvement of NEHR's technology and features to help healthcare providers quickly identify the most relevant information for their patients. Relatedly, Mr. Yip, Dr. Chu, Mr. Ho, Ms. Joan Pereira, and a number of members like Mr. Fadli Fauzi, Mr. Tiong, and Mr. Dennis Tan asked further details on the cybersecurity and incident management requirements, including the facility and availability of MOH support. So I'd like to clarify that today, healthcare providers are already required to make reasonable security arrangements to protect personal health information. This is an existing requirement in laws such as the Personal Data Protection Act and the Healthcare Services Act 2020. The Bill's cybersecurity and data security requirements are based on these existing standards and legal requirements, but contextualized for the healthcare sector. These include frameworks such as Cybersecurity Agency of Singapore's Cyber Essential Mark and the Infocom Media Development Authority's Data Protection Essentials, which were designed to be accessible and implementable by smaller organizations. And examples of these requirements include the use of anti-malware solutions and firewalls and computers, the backing up of essential business information and data storage practices. Healthcare providers will also need to train their staff on cyber hygiene and data governance practices to ensure safe and secure access to health information. On the incident management framework, healthcare providers and their HIMS providers must put in place a framework to identify, resolve, and mitigate cybersecurity and data breaches. This includes notifying MOH of prescribed security incidents and implementing mechanisms and processes to detect and respond to incidents such as ransomware attacks or unauthorized access to NEHR. But even with the best preventive measures, a data breach may still occur. Healthcare providers will be required to notify MOH and affected individuals of significant data breaches. Once notified, MOH will work with the healthcare providers to understand the root cause of the breach, the extent of the data exposed, and the potential harm to patients, and the containment and mitigation measures that need to be implemented. In the event of any data breach, healthcare providers are expected to take necessary measures to remediate the situation and prevent such incidents from occurring again. Where MOH is of the view that the mitigation or preventive measures are inadequate, We will work with the healthcare providers on implementing the appropriate measures. To Mr. Fauzi's query on how significant harm will be defined, if a data breach causes or is likely to cause a significant harm to an individual, for example, if it involves disclosure of health information that may be deemed more sensitive, healthcare providers must notify the affected individual on or after notifying MOH. Additionally, MOH will only require significant breaches to be notified in alignment with the approach under existing legal frameworks such as the PDPA. These details will be set out in subsidiary legislation. Let me now turn to the support measures for healthcare providers. I appreciate the concerns that members have raised about the support needed for smaller providers, especially smaller GP clinics. I mentioned earlier with Healthier SG, most GP clinics have already onboarded to NEHR with the support of MOH. MOH recognizes the importance of providing healthcare providers with reasonable time to comply with the HIB requirements, and will offer the necessary support for healthcare providers to prepare and adapt their system and processes. We see them as a valuable partner in supporting the continuity of care in the community. And our support package will include measures to defray costs of subscriptions to whitelisted HIB-compliant HIMS, to digitalize their clinical records, and to contribute data to NEHR more seamlessly. There are also other support packages to engage professional services from whitelisted service providers to implement cyber and data security requirements. Additionally, resources, guidance materials, and training programs will be available to help healthcare providers, including our community health partners, to meet the HIB cybersecurity and data protection requirements on an ongoing basis. We would like to reassure providers that with this support in place, healthcare providers will be better enabled and supported to implement the relevant requirements. We acknowledge the concerns raised by Mr. Yip about potentially fear-mongering tactics by some vendors. To address this, MOH is developing basic service packages specifically tailored to the needs of solo practitioners and small and medium enterprises so that they can self-help and prevent overselling of unnecessary services. We are also establishing clear guidelines for whitelisted service providers on appropriate engagement practices and transparent pricing. Healthcare providers that encounter unethical practices by whitelisted service providers can report them to MOH. Additionally, we recognize there is a small group, or what some members call the pen and paper clinics, that may face challenges in digitalizing their clinics and meeting the bill's requirements. As members highlighted, these clinics may require additional implementation support. So, digitalization is becoming key to the provision of healthcare. It's critical for clinical documentation, transmission of information between providers and laboratories, and supports timely coordination with other providers. Today, most clinics already have some form of IT system for clinic management, accounting, and billing. Going forward, digital tools will increasingly become important, enabling clinics to rely on clinical decision support systems to close care gaps and deliver safer care. Therefore, in recent years, we have strengthened the digitalization in the private primary care sector to support Healthier SG and other national initiatives. Today, about 1,100 Healthier SG clinics are on board suitable clinical management systems and contribute to NEHR. Across the GB sector, more than 80% of them are on clinic management systems. So there are a large number of clinics, vast number of them, already embarking on the digitalization efforts. And we are supporting the remaining clinics to digitalize and onboard suitable systems to enable better delivery of care. To Ms. Jones-Pereira's query if smaller clinics could collaborate on shared resources, this is a good idea for smaller clinics to explore. Currently, clinics can already join the Primary Care Network or PCNs. PCNs not only provide peer leadership and support to small or solo GP practices, they also offer administrative assistance through the PCN headquarters. The PCN will continue to offer advice and support to member clinics, share resources to smoothen the clinic's journey in digitalization and fulfilling NEHR contributions. We will further consider Mr. Dennis Tan's and Ms. Pereira's suggestions of shared IT support services as part of the rollout. I'd like to assure members that MOH is mindful of the administrative effort required to contribute information to NEHR. And this is why we encourage all healthcare providers to adopt a whitelisted HIMS, which automates the process of contributing relevant health information to NEHR. That said, for smaller clinics that may require more time to digitalize, we will make available an alternative contribution channel so that these clinics will be able to start contributing data when required, while MOH continues to work with them on their digitalization plans. Ms. Kwa reflected concerns from the ground about time and effort needed for compliance and if MOH will take these considerations in events of non-compliance, especially in the initial period. MOH has worked closely with healthcare providers and professionals and have been engaging them over the last few years. We have taken their feedback on board. First, the bill will commence in early 2027 to allow sufficient time for healthcare providers and professionals to familiarize themselves with the bill's requirements. Second, to support their transition, guidance material and dedicated support channels will be made available from the second quarter of this year to help providers and professionals understand their options and navigate the process. Third, should there be challenges complying with the bill by the required timelines, MOH will consider facts of each case carefully and assist where appropriate. So now let me turn to the comments and suggestions for support for healthcare professionals. Dr. Hamid Razak and Dr. Chu inquired how MOH intends to support healthcare professionals, noting they have concerns about increased liability arising from the HIB. I think Dr. Haresh also pointed out about concerns from healthcare professionals on medical legal liabilities and how should they think about it. We have been engaging the professional bodies and speaking to them over a period of time and have taken their suggestions, their ideas and feedback on board. MOH will publish a set of guidelines to support healthcare professionals' appropriate access and use of NEHR information. These guidelines will apply to not only to doctors, but also to other healthcare professionals assessing NEHR, such as dentists, nurses, and allied health professionals. Let me share some examples of the guidance that will be provided. So healthcare professionals have asked whether they will be required to assess NEHR for each consultation, and whether they need to review each record in NEHR when they do assess it. Assessing patients' NEHR information is not compulsory under the HIB. NEHR supports and complements existing clinical practices, including good history taking, physical examinations. HIB does not change existing standards and practices. Healthcare professionals are encouraged to consider a range of factors before deciding whether NEHR access is required for a particular consultation, such as whether more information is required based on the information gleaned from the history taking and physical examinations, or whether health records in NEHR would be relevant to the particular consultation. So we will continue to work with respective professional bodies to disseminate these guidelines to all healthcare professionals. We will also support professional bodies in ensuring their members' compliance with the bill. So on this note, I also take the opportunity to thank Ms. Kwa for co-chairing the NEHR Guidelines Workgroup Committee. So let me now turn to health information that sits outside the NEHR and the clauses in the HIB that will enable the sharing of such information. Ms. Pereira inquired about a timeline for enabling community health partners sharing of such health information to be covered under the HIB. Mr. Louis Chua asked why the HIB enables the sharing of non-NEHR health information without consent. Today, the Agency for Integrated Care, or AIC, shares data with community partners to enable them to engage and provide befriending services or care to seniors. However, on the ground, there are difficulties with obtaining consent for data sharing. Referencing my earlier example of Mr. Lim, the 72-year-old gentleman who's managing his diabetes condition. He stopped visiting his local polyclinic, and his polyclinic has faced difficulties in contacting him to obtain consent. The HIB will address this by providing an additional channel for the sharing of health information. With the HIB, Mr. Lim's polyclinic can potentially share his contact information and broad health risk indicators, such as indication of the presence of frailty or chronic conditions with AIC, without the details of specific medical conditions. AIC can then prioritize engaging Mr. Lim to check on his well-being and link him with necessary support as needed. On whether to include other community health partners like active aging centers and use cases in the future, MOH will carefully assess whether these other entities and use cases facilitate quality care and care continuity for patients. We will consider their readiness to meet the various responsibilities that come with sharing health information, such as the cybersecurity and data security requirements under the bill, and we will consult key stakeholders.
SMS Tan, if I could just ask you to hold on for a minute because you've reached your time limit. So, Deputy Leader.
Mr. Speaker, may I seek your consent and the general assent of members present to move that proceedings on the item under discussion be exempted from the provisions of Standing Order number 48.8 to remove the time limit in respect of SMS Tan's speech, please.
I give my consent. Does the Deputy Leader of the House have the general assent of honourable members present to so move? Deputy Leader, please proceed.
Speaker, I move that the proceedings on the item under discussion be exempted from the provisions of Standing Order number 48.8 to remove the time limit in respect of SMS Tan's speech.
The question is as moved by the Deputy Leader of the House. Those who agree, say aye. Those who disagree, say no. I think the ayes have it. The ayes have it. SMS Tan, you may resume.
So we will consider the readiness to meet the various responsibilities that come with sharing health information, such as various requirements under the bill. Any community health partners which are added will be publicly communicated, including through MOH's website. So to conclude, the HIB will help us achieve the goal of one patient, one health summary, one care journey. We will work with and support healthcare providers and healthcare professionals in achieving this goal. Through our collective efforts, Singaporeans can benefit from better coordinated care, enhanced quality of care, and lower costs. So I believe that I've addressed the questions raised by all the members, and I'm back to move.
Are there clarifications for SMS Tan? Mr. Kenneth Teo.
Thank you for clarifications. Thanks, SMS. So I mentioned the possibility of insurance. So you mentioned that there'll be cost support, but is there a reason why insurance is not offered rather than general cost support? That's clarification one. Clarification two, I thank the Minister for, SMS for saying there will be flexibility for IT incapable practices, such as the senior GPs that who are my constituents. Can you just double click and explain a bit what this flexibility for IT incapable practices might entail? Three, what I think I didn't hear an answer to what if there is a data breach? Can the insurers now use the now public information in the data breach? And I thank him for his response to my concerns about the inspection and right to audit clauses. Now, your response is that doctors should carefully assess what is relevant. Now, I think that this may not be a great solution because I think the doctor is sort of caught in the middle, right, between the insurer and the patient, and they have to bear liability for the judgment calls as to what they put in the notes. So I think what's probably going to happen is that there's going to be a chilling effect, right, where doctors will start avoiding documenting any sensitive data, both in their own medical records, but also perhaps in the NEHR as well. And so if it percolates up to the NEHR, wouldn't the NEHR utility be undermined if you can't trust what to input? So I mentioned in my speech that it might be better to just go downstream and just say that work with MAS to prohibit insurers from requiring NEHR-derived information as a condition of coverage, claim processing, and policy renewal. And if I may, that's kind of a significant part of why I posed a PQ to Minister Ong earlier today about needing a dual regulation framework by MES and NEHR for insurers so that someone is cleanly accountable for insurer behavior as a health system actor. Thank you.
SMS Tan.
So I thank the member for his clarifications. I believe there are 4 clarifications, and I take them in turn. One about offering cyber insurance to GP clinics. Can I just get a member to confirm that this is what he's asked about? Okay. We will. In my speech, I did outline the few measures that we're putting in place, and we will continue to put in place to support GPs, especially smaller GPs, to comply with the HIB requirements, including data security and cybersecurity. And there are a number of support packages we are discussing with them, and these details we will make known in due course. So that's one. We are supporting them, and we want them to travel the journey together with us. And there is broad support among the doctors, including those small GPs who see the value of contributing to and assessing NEHR, and most of the GPs are already on board. And they understand the need for the cybersecurity and data security requirements under bill to protect the data. And we are working with them to look at the various whitelisted services and the management systems they can adopt to meet the requirements. In terms of cybersecurity insurance, this is something we certainly will consider, but today, unfortunately, there isn't a very mature market for cybersecurity insurance, especially for GPs. So if this is something useful, we will certainly consider as part of the support packages and discussion with the relevant stakeholders. Second, about flexibility for senior GPs or smaller GPs, I mentioned the support packages we do intend to provide for them, including funding support, whitelisting service providers, and the different management systems. But I think what we want to avoid is having different standards of cybersecurity and data security requirements for different clinics based on their size. I think that is not the sensible and practical way to do it, as mentioned by different members earlier. It's about making sure that different clinics, different touch points to the NEHR system meets the appropriate level of cybersecurity and data security requirements, and find ways of uplifting the different GPs. And we will certainly do so in the coming months and years. Could you clarify on the third question for this?
Data breaches, if there's a data breach.
So this is part of the, it's quite clear that the insurance companies can't assess NEHR for insurance or employment purposes. But if data breaches, I think it all boils down to the ethical considerations of how they assess those data breaches in the first place. And that's something we have to work together with the MES as a regulator, together with insurance companies, on understanding how they're using those information. And I think that is something that we frown upon. We're using NEHR data for purpose of insurance. But it's a hypothetical scenario, I think something we have to think through. On about a dedicated regulation around insurance, or whether they should just prohibit, these are or putting the healthcare providers or professions in a very difficult situation. This is something we're working through with the healthcare providers, the industry associations, as well as together with MES with the insurance industry. In fact, I mentioned earlier in my opening speech that, in my closing speech, the MOH has issued guidelines to the insurers and the doctors on how we should think about the HIB when it's enacted. And we'll certainly work closely with MES as a regulator for the insurance industry. But I think quite clear, the principle and approach under the HIB is that we prohibit the use and access of NEHR information for employment and insurance purposes. And we have to work through the insurance associations, the MES, the professional bodies, including the healthcare professional bodies, on how it's implemented on the ground. But assurance to the public and to those members who spoke about it is that our approach and position is quite clear. I believe that he has, did I answer all your 4 questions? Okay.
Mr. David Ho.
I thank the SMS for the response and the reassurance. SMS, I would like to clarify a comment that I made earlier. I wonder if I heard clearly that the access to information to electronic medical records by healthcare professionals will be captured in the National Electronic Healthcare Records Access History. I ask this because the Singaporean who was particularly concerned about this bill sent me the URL to the FAQ in Health Hub that reads, your healthcare professionals may be accessing your records from their own electronic medical record systems. Access made to your records in their EMR systems are not included in the NEHR access history. I'll be happy to share the URL. I just wanted to clarify whether if what I heard was correct. Thank you.
SMS Tan.
So just to clarify, access to NEHR, even through the EMR, will be logged as an audit access to NEHR. But assessing a patient's records on the institutions, healthcare institutions' own EMR system, electronic medical record system, is separate. It's an internal operation system for the hospital, for the polyclinic, or for the private healthcare clinic. So it's quite different. But you use EMR to log to NEHR, the logs will be recorded and tracked.